topic that we've been discussed for today is all about the stability and mobility chain. So when we say stability, it is a may be defined as the capacity to control the position or movement of a joint or a series of joints. And mobility, it is may be defined as the capacity to create the appropriate quality of movement around and across joint or joints. So to further more explain about the relationship between stability and mobility, let's all watch the video.
One of the things we talk about is the stability-mobility continuum. And it's kind of an interesting concept. And if you think about normal movement in the human body, joints are either designed to be relatively stable joints or they're designed to be mobile joints to produce movement. If you look at the hips, our hips are designed to be very mobile. It moves in 3 planes of movement, so sagittal, coronal, transverse plane. The next region we come to is sort of the lumbar pelvic area, or another term we use often in training, the core should be nice and stable. I move to my next region up. Thoracic spine is designed to be mobile, which allows our trunk to turn. Now the next couple things I work out to, scapulothoracic joint. Scapulothoracic joint's designed to be stable. If I go to my next joint out, shoulder, glenohumeral joint. Glenohumeral joint is highly mobile. Next thing out, the elbow, stable. Or if I even drop down from my hips, we had mobile hips, knees as a hinge joint should be stable. Our ankle is mobile. Now you say to me, why is this even important to us? Because that's normal function. Here's what's interesting and what we see all the time, and we can actually even pick up with our SFMA as one of our cornerstones here. And that is when there's problem in a joint, or if a joint flips itself. For example, let's take a very common pathology. Individual has hip osteoarthritis and they start to lose mobility. So guess what? This becomes stable now. There's not movement going on at the hip. All that movement that used to take place here is going to get shifted above and below. So guess what we start to see? Lumbar spine or our core becomes unstable or hypermobile. We go up to the next segment. The thoracic spine becomes stable. Scapulothoracic joint becomes mobile where it used to be stable. We lose motion at the shoulder, or perhaps we drop down. If the hips aren't moving, a lot of that force is going to get transferred to the knee. It becomes now a mobile joint. So what we start to see happening is, and the whole tenet of what we like to look at with our stability and mobility continuum, is that when we identify a joint that's become mobile, or hypomobile, and that part would lack mobility, it's reasonable to assume, or we know, those adjacent joints are going to have excessive movement. Where does a person complain of pain? The joints that have excessive movements. So when a person comes in and complains of low back pain, and we look at it, and through our global assessment, we find out they're not having any movement at all, or there's limited movement at the hips, and we start focusing here, it's reasonable to assume we take the stress off the lumbar spine, put it back where it needs to be. Patients often say to us, well, we don't know why you're looking at my hips don't hurt. And my comeback is, well, of course they don't hurt. They're not doing anything. The hips aren't doing anything. They're stuck. They're not mobile. It's the joints above and below that are taking all the force that's causing the symptoms. So again, we use the stability mobility continuum to try to identify areas where there's mobility restrictions. And then as we set up our treatment program, as we become more efficient in setting up our treatment program, we attack those mobility dysfunctions first. And oftentimes, all we have to do is restore mobility back to the joints where it's not happening, and all these other dysfunctions we see will flip. They'll take care of themselves. The core will come back to be stable, but it's not going to be stable if the joints adjacent to it are driving it to be unstable.
This is the fundamental concept. Stress. Stress is defined as a non-specific response to any stimulus that overcomes or threatens to overcome the body's ability to maintain the homeostasis. Homeostasis, it is the equilibrium of the body's internal biological mechanisms. And stressors may originate from many different sources, but manifest themselves physiologically within the body, or the sources include also the physical, the gravity or ground reactive forces, physiological, the pain, vigorous exercise, glycogen depletion, or dehydration. The environmental, if it is hot or cold. Nutritional, inadequate caloric intake, nutrient deficiencies, or skip meals. And also the psychological or emotional, the sorrow, fear, or anxiety. And also the chemical, blood acid-base imbalance, or lower oxygen supply. And lastly, the social sources, the life events or the personal conflicts. Integrated kinetic chain consequences. These actions are not limited to nerves, instructing muscles to contract concentrically, the shortening, and eccentrically, the lengthening against bones to move joint. So in picture A, shows that the muscles contract in shortening, and the picture B shows the muscles contract in eccentrically or the lengthening of the against bones to move the joints. So, but also involve nerves instructing other muscles to contract isometrically, no change in muscle length to hold a joint position. And letter C defined or shows us there is no change in muscle length. The fundamental movement. The ankle, in contrast, moves through various movements during walking. In the sagittal plane, the vertical plane moving front to back, the ankles move through supination and ankle rolling outward at heel, strike and pronation, the ankle rolling inward as the foot makes full contact with the ground. Flexion at heel strike called dorsiflexion and a form of extension as one pushes off of the plantar flexion. This movement in multiple planes qualifies the ankle as a more mobile joint. Transfer of loads and forces throughout the body. To generate the force, the body requires a stable point from which to create an action and tolerate a reaction. Typically, this represents a fixed anchor point, example given the ground, bench, wall, and backrest of a chair, that allows the body to express the energy it has stored in the muscles, tendons, and fascia as force. The injury prevention. With more than 200 joints in the body, stability is a top priority. If the joints in the body are not stable, the surrounding soft tissue structures and even the bones themselves could be injured. Stable joints help prevent both microtrauma and the acute injuries such as a sprain or fracture, and a repetitive microtrauma or the chronic injury caused by overused or repetitive poor form. So when we say macrotrauma, it is occurs when a force is placed on the body or joint and it exceeds the stability level or ability to maintain stability within the joint. Examples include sporting accidents where impact forces from the ground or from collisions with the opponents are large and results in an injury. However, it may also occur because of the body's inability to tolerate the forces imposed on the body during an activity. Example given is throwing out the back while lifting. And when we say microtrauma, it is a more challenging issue to specifically identify in comparison with macrotrauma. It is attributed to the fact that the injury that occurred to the body could have resulted from weeks, months, or even years. of repeatedly applying a small stress on a body segment that went unnoticed until the accumulation results in an injury. Stability system. Stability within the body can be classified in two ways: the local stability and the full body or global stability. When we say local stability, refers to stability provided by each individual joint with the body, whereas full body stability refers to the overall stability of the body, which is the sum of all the local stability links in the kinetic chain. The four components of Punjabi's model. First is the passive system. The passive system relies on structures that essentially remain consistent in their size, shape, and length, which all contributes to the stability within that joint. For example, if you compare the ball and socket joints of the hip and shoulder, the acetabulum or the socket of the hip is much deeper than the glenoid fossa or the socket of the shoulder. Second is the active system. The active system consists of the muscular system. Muscles actively contract and provide necessary stiffness to a joint by creating tension to aid in stabilization. This mechanism typically consists of a contraction of muscles that cross a joint from all angles. For example, the chest and posterior shoulder muscles contracting will help stabilize the shoulder joint. Third is the control system. The control system refers to the aforementioned software of the body of the neurological contribution to stability. The control system depends on interpreting the incoming sensory information, or the afferent, and then formulating a plan to execute an action to respond, or the efferent. Lastly is the actively passive system. The actively passive system is composed of the facial tissue and how it is arranged throughout the body. Although previously defined, fascia constitutes as a form of connective tissue that is different from the traditional collagen and elastin tissue found in muscle, but it does contain myofibroblasts, which are specialized muscle cells that can undergo contraction and shortening. The role of posture in the stability-mobility relationship. Static posture, or the how an individual stands, is one of the fundamental way to gather information on the relationship between stability and mobility, as postural alignment demonstrates balance between opposing muscles groups at each joint. The static posture is a reflection of three important elements of the neuromusculoskeletal system: the nerves, muscles, and bones. The muscle balance, neuromuscular coordination, and the mechanical efficiency. Each of these elements is interdependent, and each is essential to the functional stability-mobility relationship of the musculoskeletal system. So, as you can see in the picture, the poor posture if you have a forward head and flat back. Poor posture if you have a forward head, rounded shoulders, and sway back. If you have a good posture, you have a balanced upright posture. To further explain about this, let's hear from Go.